Good morning, colleagues. Today we will be discussing the operative management of sacrococcygeal teratoma, an entity that, in my view, represents one of the most intellectually demanding and technically unforgiving operations in all of pediatric surgery. When you sit across from parents cradling a neonate with a mass that can literally rival the size of the baby's head, or when you face a 4-year-old referred late with a malignant type 4 presacral lesion, the weight of what we are about to do is immense. My objective is not merely to walk you through textbook steps, but to give you a deep, evidence-informed understanding of every decision point, from the embryological basis of the disease to why the coccyx must come out, to how you reconstruct the buttocks to give your patient the best functional and cosmetic results. So let's begin. Our objectives today are structured to mirror the cognitive hierarchy of surgical decision making. We start with the why, embryology and classification, because understanding where this tumor comes from is not merely academic, it directly informs our operative strategy. We then move to anatomy, which is the surgeon's map. From there, we address indications, timing, preoperative optimization, anesthesia, the operation itself in granular step-by-step detail, and we'll finish with complications, surveillance, prognosis, and the particular challenges of practicing in a resource-limited environment like ours. By the end of this talk, you should be able to independently plan and execute the operative management of sacrococcygeal teratoma and counsel families intelligently about what to expect. The outline you see here is deliberately comprehensive. Some of you may wonder why sections like historical perspective and future trends appear in what is ostensibly an operative talk. I would argue that the historical perspective gives us the intellectual scaffolding. Understanding what Gross and Clatworthy discovered in 1951 is what stops you from inadvertently leaving the coccyx behind. And the future trend section is not idle speculation. For many of you who will train the next generation, robotic surgery, fetal intervention, and AI-assisted surgical planning are not distant futures. They are present realities in the centers to which we refer our most complex cases. So we'll touch on all of this, though the operative technique will occupy the greatest portion of our time. Sacrococcygeal teratoma, or SCT, is the most common extragonadal germ cell tumor in children. The incidence is approximately 1 in 35,000 to 40,000 live births, though some series place it to be as frequent as 1 in 27,000. The female predominance is striking, a female to male ratio of approximately 4 to 1, a disparity that has not been fully explained but is consistent across virtually every published series globally, including our own Nigerian data. The tumor arises from pluripotent embryonic germ cells, specifically cells that normally migrate from the yolk sac to the gonads during embryogenesis, but in the case of SCT, appear to remain sequestered in or near the coccyx and undergo disorganized differentiation. Because these cells are pluripotent, the resulting tumor contains elements from all three germ layers, ectoderm, mesoderm, and endoderm. Hence, the finding of teeth, hair, neural tissue, cartilage, and gut epithelium within the same specimen. This is not a curiosity, it is a direct consequence of the biology of totipotency. Fee et al. In 2021 is a highly cited review that describes SCT as a tumor at the center of embryogenesis, noting that studying these tumors has advanced our understanding of how germ layer specification and organogenesis can go awry. For us as clinicians, the take away from this biology is that complete surgical excision remains the cornerstone of treatment. There is no targeted biological therapy, no effective ablative radiotherapy, and for malignant cases, chemotherapy is an adjunct, not a substitute for surgery. Outcomes depend critically on three variables: timing of intervention, histologic characteristics, and the extent of pelvic involvement. Now, let us ground this in our local context because the epidemiology and clinical presentation of SCT in Nigeria differs meaningfully from what you would read in the European or North American literature, not in biology, but in the circumstances under which patients present to us. The Ibadan series, one of the earliest Nigerian reports, reviewed 31 children and found that two-thirds of all teratomas were sacrococcygeal. Malignancy was documented in approximately 25%, and malignancy was strongly associated with pelvic and intrapelvic extension. This is critically important. A predominantly external tumor in a neonate tends to be benign, whereas a tumor with a dominant intrapelvic component presenting later in childhood carries a far higher malignancy risk. This is not coincidence, it reflects the natural history of untreated or undetected SCT. The JOS series of 38 children seen between 1990 and 2008 by Childan et al. Reported a marked female predominance of 31 out of 38 patients. 61% presented in the neonatal period, but a significant proportion presented later in infancy and childhood, reflecting the reality that late presentation is common in our setting. 4 patients had malignancy at initial presentation and 2 developed recurrence on follow-up, with 24% experiencing long-term functional issues, including bowel and bladder dysfunction. The Maiduguri series of 21 cases over 18 years by Abubakar et al. Reported that 80% were girls and 61% presented in the neonatal period. 3 had malignancy at presentation and 1 developed a malignant recurrence. The preponderance of benign neonatal presentation in these series does not mean that malignancy is not a concern. It means that we are seeing the early end of the spectrum, and that older children with late presentations carry much higher malignancy risk, as has been consistently demonstrated in global literature. So here's the paper by the Ibadan fellow, where they had a series of 31 cases, and then here's a paper by Childan et al. From Jos, and then here's a paper from the Maiduguri series by Abubakar et al. Now to some key definitions. Let us establish precise terminology because imprecise language in surgical oncology leads to imprecise decision making. Sacrococcygeal teratomas are mixed neoplasms containing 2 or more germ layer derivatives. Histologically, 3 categories exist. The mature teratomas are composed entirely of well-differentiated benign tissues. All 3 germ layers are represented, but the cells look like normal adult tissue. These carry an excellent prognosis. Immature teratomas contain varying amounts of undifferentiated or embryonic appearing tissue, most commonly neuroectodermal elements. The grade of immaturity, that's grades 1 to 3, on the Gonzalez-Kruszy scale, predicts the risk of recurrence and malignant transformation. Grade 3 immature teratomas are particularly worrying in children older than 12 months. Then we have the malignant teratomas, which contain frankly malignant germ cell elements. The most common malignant component is yolk sac tumor, also known as the endodermal sinus tumor, which secretes AFP. Choriocarcinoma, germinoma, embryonal carcinoma are less common components. The presence of malignant elements fundamentally changes the oncologic management. These patients require adjuvant platinum-based chemotherapy, that is the BEP or BEP, which is bleomycin, etoposide, and cisplatin, in addition to surgical resection. The Altman anatomic classification, published in 1974 and still the universally accepted system, is built on one clinical insight: the surgical approach, the bleeding risk, and the functional outcome are all directly determined by how much of a tumor is internal versus external. Type 1 tumors are predominantly external, with minimal or no presacral extension. These constitute roughly 46% of cases in large series and are the most amenable to a pure perineal approach. They are visible at birth, grow away from the pelvis, and have the lowest risk of malignancy. Type 2 tumors are mostly external but have significant intrapelvic extension. You can palpate the intrapelvic components in rectal examination and you can see it on imaging. These make up approximately 34% of cases. Type 3 tumors are predominantly intrapelvic with only a small external component. The external components may be subtle, perhaps just a skin dimple or a slight fullness at the sacrococcygeal area. These patients may present with constipation, urinary retention, lower limb weakness from mass effects. They constitute about 9% of cases. Then we have the type 4 tumors, which are entirely presacral with no external manifestation. These are the most insidious. They present in older children with vague pelvic symptoms. And by the time of diagnosis, malignancy rates approach 50% or higher. They make up approximately 10% of cases. This classification system is not merely descriptive, it is the primary determinant of surgical approach. Knowing the Altman type before entering the operating room is non-negotiable. Why is surgical resection so important and why must it be done promptly? 4 reasons, all evidence-based. First, risk of malignant transformation. The risk of malignancy increases dramatically with age. In neonates, malignancy rates are approximately 10%. By the age of 2 months, the risk begins rising. In children presenting after age 4 months, malignancy rates may exceed 50% in some series. The mechanism is thought to be continued proliferation and progressive dedifferentiation of residual totipotent cells, particularly those in the coccyx. In the absence of surgical extirpation, this is why a mature-looking tumor in an older child must not provide false reassurance. Second, prevention of acute complications. Large, highly vascular tumors can cause high-output cardiac failure, a well-recognized phenomenon where the tumor acts as an arteriovenous fistula, causing left ventricular volume overload, cardiomegaly, and hydrops fetalis. Slievepov and Peredere et al. And Camara et al. Have documented this. Tumor rupture during delivery, hemorrhage from spontaneous erosion of the tumor surface, and obstructive uropathy or rectal obstruction from large intrapelvic components are all life-threatening complications of delay. Third, curative potential. Complete en bloc resection and coccygectomy achieves 94 to 95% 5-year overall survival for benign lesions, outcomes that are difficult to replicate with any other intervention. The surgery is definitive. Fourth is a functional preservation. Waiting for the tumor to grow larger makes pelvic dissection more hazardous to the rectum, bladder, and pelvic nerves. So the window for nerve-sparing resection is widest when the tumor is small and the planes are clear. Now to the surgical anatomy. The primitive streak actively forms mesoderm until the 4th week. Then it diminishes in size and becomes an insignificant structure in the sacrococcygeal region of the embryo. Normally, the primitive streak undergoes degeneration and disappears by the end of the 4th week. I cannot overstate the importance of this section. A surgeon who does not understand the anatomy will injure the rectum, miss the median sacral artery, or leave a coccygeal remnant behind, all of which have devastating consequences. Let's also orient ourselves. The sacrococcygeal region is bound superiorly by the sacrum, laterally by the piriformis muscle and sciatic notch, anteriorly by the presacral fascia, which is the posterior wall of the rectum, and inferiorly by the gluteal musculature and perineum. The coccyx, which is four fused coccygeal vertebrae, sits at the apex of this region. And it is precisely here that the pluripotent cells give rise to SCT. This is where they are concentrated. The coccyx must be removed and blocked with a tumor without exception. The totipotent cells from which SCT arises cluster at the tip of the coccyx and leaving even a fragment of coccygeal tissue elevates recurrence rates dramatically from less than 10% with complete coccygectomy to 37% without it, as the landmark series established. The rectum and the sphincter complex lie immediately anterior to the tumor and its presacral extension. The key dissection plane is the avascular areolar tissue between the presacral fascia, which is adherent to the posterior rectal wall, and the tumor capsule. If you violate the presacral fascia, you are on the rectal wall. This is why a rectal bougie or Heger's dilator placed in the rectum at the start of the case is not optional. It is a structural navigation tool. Then there's the median sacral nerve. Median sacral nerve is the primary vascular feeder of the tumor. It arises from the aorta just above its bifurcation, descends along the anterior surface of the rectum in the midline, and enters the tumor from its superior pole. In large vascular tumors, this vessel can be the size of a significant artery. Its avulsion or delayed identification is the cause of catastrophic intraoperative hemorrhage. So early control of the median sacral artery, either via the abdominal approach in complex cases or carefully from below in pure sacral approaches, is the single most important hemostatic maneuver of the operation. Then of course there's the presacral fascia, which is our dissection guide. Staying in the correct plane. Staying in the use the presacral fascia here. You can see that, which is the pelvic fascia. So staying in the correct plane outside the fascia and directly on the tumor capsule protects the rectum. This practical way to ensure this is to use a combination of sharp and blunt dissection. Keep your dissection on the glistening capsule of the tumor and have a finger in the rectum to periodically confirm you are not near the rectal wall. The vascular supply of these tumors is multifactorial, and this is why preoperative vascular imaging and careful intraoperative planning are so important. Beyond the median sacral artery, the tumor receives contributions from branches of the internal iliac arteries, particularly the internal pudendal artery, the lateral sacral arteries. So for giant tumors, all of these feeders may be significantly enlarged. Elgendi and Amoa et al. Emphasize the early control of these vessels being critical to prevent catastrophic hemorrhage. The structures at risk during dissection deserve individual mention. The rectum and anal sphincter complex. Injury leads to immediate fecal contamination and the need for a colostomy. Even a small rectal perforation, if unrecognized, causes peritonitis and potentially septic deaths. This is why the bougie stays in throughout the dissection and why you must feel with your non-dominant hand as you cut. The bladder and pelvic autonomic nerves. The pelvic plexus, basically the superior and inferior hypogastric plexus, provides both sympathetic and parasympathetic innervation to the bladder and distal bowel. These nerve fibers run as thin web spaces in the loose connective tissue lateral to the rectum and bladder. Injury causes neogenic bladder, often manifesting as urinary retention or incontinence, and is reported in 13 to 24% of patients in long-term follow-up series by that of the Algendi et al., Fumino et al. The risk is higher for Altman 3 and 4 tumors where the dissection is deep in the pelvis. Then there's the sacral nerve roots S2 to S4. These exit through the sacral foramina and contributes to the pudendal nerve, providing motor and sensory innervation to the pelvic floor, anal sphincter, and perineum. Injury causes lower extremity motor deficits and impaired sphincter function. In children with large tumors involving the sacrum or with intraspinal extension, as documented by Aspang et al., sacral root injury is a real risk. Now, the ureters, they are particularly at risk during abdominal mobilization of large type 3 and 4 tumors, where the cause of the ureter can be displaced and distorted by the tumor mass. And then lastly, the levator, inner and pelvic floor muscles, which division of these muscles during resection must be followed by meticulous reconstruction to prevent pelvic floor weakness, prolapse, and loss of sphincter support. Understanding the history of SCT surgery is not about nostalgia, it is about understanding why we do what we do, particularly why every single case must include a coccygectomy. Rudolf Virchow first described Sacrococcygeal teratoma in 1869, deriving the name from the Greek teras, meaning monstrous. For nearly a century afterward, SCT carried a grim prognosis. Massive hemorrhage and high recurrence rates made it a surgical catastrophe. The most transformative contribution in the history of SCT management came in 1951 from Gross and Clatworthy at Boston Children's Hospital. They made the oncological observation that totipotent cells, the seed cells of the tumor, are concentrated in the coccyx. When they began removing the coccyx en bloc with every tumor, the recurrence rate dropped from nearly 40% to less than 10%. This is arguably one of the most impactful technical insights in the history of pediatric oncological surgery. The coccyx is not an innocent bystander, it is the origin of the disease. Leaving it behind, even partially, is not a variation in technique, it is an oncological error. The Altman classification of 1974 gave a common language and a framework for approach selection. For the first time, the anatomical location of the tumor could be systematically related to the surgical strategy. So the focus of modern era has shifted from survival to minimizing morbidity. The introduction of fetal surgery for SCT in the late 1990s by Adzik, Harrison and colleagues at Children's Hospital of Philadelphia and UCSF opened the possibility of intervening before the tumor causes irreversible cardiac compromise. Open fetal surgery and, more recently, radiofrequency ablation for hydropic fetuses represents a paradigm shift in the most severe cases. Modern advances include early ligation of the median sacral artery, which is now recognized as the single most important maneuver to prevent intraoperative exsanguination, and then laparoscopic assistance for complex intrapelvic tumors, and cell salvage devices to manage massive blood loss. Surgery is indicated in virtually all cases of SCT upon diagnosis. This is almost unique in surgery. There are very few situations where a tumor universally mandates operative intervention, regardless of age, size, or histology. The reason is simple. There is no effective non-operative treatment, and the natural history without surgery is progressive growth, worsening morbidity, and increasing malignancy risk. The absolute indications are straightforward. All resectable SCTs, whether benign or malignant, in any patient from the neonate to the elderly adults. An antenatally diagnosed SCT is planned for postnatal resection. A visible sacrococcygeal mass at birth demands urgent evaluation and timely surgery. Symptomatic tumors causing rectal or urinary compromise represent a surgical urgency. Regarding optimal timing, the evidence strongly supports early neonatal resection, ideally between days 8 and day 10 of life in uncomplicated cases. Why not day 1 or 2? Because the first few days are used for physiologic stabilization, full imaging workup, tumor marker measurements, blood product preparation, team preparation. Why not wait longer? Because of the malignancy clock and the risk of tumor complications. So for complicated presentations vis-a-vis hemorrhage, high output cardiac failure, tumor rupture, surgery must be performed on an emergency basis immediately after birth, regardless of the infant's maturity or weight. In these situations, the tumor itself is a life-threatening emergency. Giant cystic tumors that cause respiratory compromise from diaphragmatic splinting may benefit from staged cyst decompression prior to definitive resection, and giant solid or mixed highly vascular tumors may require preoperative devascularization, either endovascular or open, before resection to reduce the risk of intraoperative exsanguination. The statement that there are no absolute oncological contraindications to SCT resection is carefully nuanced. The tumor cannot be managed operatively in the long term. However, there are several important relative or temporary contraindications that must be respected. One is uncorrected severe cardiopulmonary compromise. A neonate in high output cardiac failure with a dilated polycontracting ventricle is not a safe surgical candidate until optimized. Given diuretics, addressing pulmonary hypertension, and ensuring hemodynamic stability are not optional preliminaries, they are life-saving preparations. Secondly is initially unresectable tumor. For malignant SCTs with extensive local infiltration or where safe resection cannot be achieved without catastrophic organ sacrifice, biopsy followed by neoadjuvant platinum-based chemotherapy is the appropriate strategy to downstage the tumor before definitive surgery. Then, the prohibition on routine preoperative biopsy of clearly resectable SCTs deserves special emphasis. Transrectal or transcutaneous biopsy tracts can seed the presacral space with tumor cells, converting a curable surgical disease into a disseminated one. The imaging characteristics and tumor markers are almost always sufficient for diagnosis. Fee, Yadav, and Womurushka and Lodhia et al. Are consistent on this point. The biopsy a resectable SCT in a neonate. If you do this, this has no legitimate indication. Now, lastly is the uncorrected coagulopathy, particularly Kasabach-Meritz phenomenon in large vascular tumors, must be corrected preoperatively. Operating on a coagulopathic neonate with an SCT is a recipe for uncontrollable hemorrhage. Preoperative preparation for SCT resection is among the most demanding in all of pediatric surgery. This is not an operation you walk into cold. Every member of the team, surgeon, anesthetist, neonatologist, blood bank, must be prepared for what is effectively a potentially exsanguination event. Prenatal diagnosis has transformed the management of SCT in well-resourced settings. Routine obstetric ultrasound at 18 to 20 weeks identifies most type 1 and type 2 tumors as a sacral mass. Fetal MRI adds critical information distinguishing solid from cystic composition, assessing vascularity, whether a solid hypervascular tumor is there, which is far more dangerous than a cystic one, defining pelvic and abdominal extension, and informing the delivery plan. The evidence supports elective cesarean section for tumors that are greater than 5 cm because dystocia during vaginal delivery can cause tumor avulsion, hemorrhage, or rupture, which are all potentially fatal. In our setting, most patients present postnatally, and the diagnosis is usually obvious on clinical examination. A large pedunculated sacrococcygeal mass in a newborn is unmistakable. For older children presenting with constipation, a pelvic mass on DRE, or neurological symptoms, imaging is essential to confirm diagnosis and determine tumor extent. The pertinent history must specifically inquire about the antenatal period. So gestational age, because prematurity is common with large vascular tumors. Any fetal complications such as polyhydramnios suggesting high output states or esophageal compression. Evidence of fetal hydrops or any intervention, and the mode of delivery. If the patient was delivered vaginally despite a large tumor, the possibility of traumatic injury to the tumor surface must be considered. A critical important association is the mirror syndrome, also known as the Ballantyne's syndrome. When the fetus develops hydrops from an SCT, the mother can develop a severe preeclampsia-like syndrome, mirroring the fetal condition. This maternal emergency must be recognized and managed, and it represents an indication for emergency delivery and concurrent surgical planning. In the postnatal period, cardiorespiratory status, vis-a-vis tachypnea, grunting, and poor feeding may indicate high output cardiac failure from the arteriovenous shunting within the tumor. Voiding and defecation patterns to establish baseline pelvic nerve function, and any signs of tumor bleeding, ulceration, or rupture should be taken note of. Physical examination of a neonate with SCT must be systematic and complete. On general assessment, we look for signs of respiratory distress, hemodynamic instability. A pale tachycardic neonate with a large hypervascular tumor may be incompensated high output failure. Hepatomegaly suggests cardiac compromise. Tumor assessments follows the Altman framework. Is the tumor predominantly external, type 1, or is there a significant intrapelvic component on bimanual examination? We document size precisely in centimeters, as the tumor to birth weight ratio is an emerging prognostic metric, as evidenced by paper by Park et al. So we want to document consistency. Cystic tumors are generally lower risk than solid or mixed tumors. Assess skin integrity, whether there's ulceration, necrosis, dilated superficial veins indicate a highly vascular, potentially unstable tumor. These detailed assessments, including the dilated surface veins, are they're actually miniature arteriovenous malformations, and they can rupture spontaneously. Digital rectal examination is mandatory to tell you the cephalad extent of the pelvic components, the relationship of the tumor to the rectal wall, whether the rectum is anteriorly displaced, posterolaterally displaced, or frankly compressed, and gives a tactile sense of the plane that will guide your posterior dissection. It must be performed gently to avoid perforation of the tumor in direct contact with the rectal wall. Neurologic assessments. These are checking for anal sphincter tone. Is it normal, patulous, or hypertonic? Want to perform the anal wink reflex, assess the lower limb movements, the tone, the perineal sensation. All of these establish a baseline and identify pre-existing neurological compromise that may be attributed to sacral root involvement. So here's an image showing the huge Altman type 1 SCT. And here's another one showing what was an Altman type 2 SCT. Here's one that shows an ulcerated Altman type 1 SCT. You can see the ulceration evidence. And then here we see another one ulcerated but is not widespread like the initial one. And here we see an example of a ruptured SCT. So this has ruptured, was cystic ruptured and had released some fluid. So here we can see the wrinkling on the surface. Here we see a child who has bled into an SCT. So we have a hemorrhagic SCT. The hematologic workup is the foundation of operative safety. So we begin with a full blood counts. Anemia and thrombocytopenia must be corrected preoperatively. So cross-matching is mandatory. Elgendi et al. And Chowdhury et al. Specifically recommend preparing 2 to 4 units of packed red cells and fresh frozen plasma before entering the operating room. In large or solid vascular tumors, I would argue that 4 units is the minimum, and the blood bank must be on standby for more. Blood loss in these cases can exceed the infant's total blood volume in minutes. The coagulation profile vis-a-vis the PT, APTT, and fibrinogen must be checked to exclude consumptive coagulopathy. Remember, Kasabach merits phenomenon, while more commonly associated with hepatic hemangiomas, can occur with large sacrococcygeal teratomas. So a profoundly thrombocytopenic coagulopathic neonate is not safe for surgery until corrected. Then tumor markers are critically important. Alpha fetoproteins must be measured preoperatively in every case without exception. It serves 3 functions. It helps confirm the diagnosis of a germ cell tumor. It establishes the baseline for postoperative monitoring, and it guides prognostication. A crucially important caveat is that AFP is naturally extremely elevated in neonates. At birth, normal AFP are in the range of 40,000 to 100,000 nanogram per ml and decline exponentially over the first 6 to 9 months of life. So interpreting an AFP of 5,000 nanogram per ml in a 3-month-old as normal when the age-adjusted reference range already expects a level of around 100 nanogram per ml by that age could mask residual disease. So failure to use age-adjusted normal values is one of the most common errors in postoperative surveillance. Beta HCG is measured to exclude malignant non-seminomatous germ cell components, particularly choriocarcinoma. Neonates with large tumors are effectively catabolic. The tumor is a metabolic burden, causing hypermetabolism, protein consumption, and often anemia. Serum albumin and prealbumin reflects protein reserve and wound healing capacity. In urgent cases, these are corrected postoperatively, but where surgery is planned semi-electively, even a few days of optimized enteral nutrition can make a meaningful difference to wound healing. Total parenteral nutrition may be considered for neonates with bowel obstruction from the tumor mass, or for older children with significant hypoalbuminemia. Remember that the perineal wound sits in immediate proximity to the anus, and wound dehiscence rates in malnourished patients can reach alarming proportions. So some series reporting dehiscence in up to 90% of cases. Now to radiological investigations. MRI is the gold standard for preoperative assessments. No other imaging modality provides the combination of soft tissue contrast, multi-planar capability, and anatomical resolution necessary to plan SCT surgery. On MRI, you can delineate the relationship of the tumor to the rectum, the bladder, the sacrum, and pelvic vessels, the degree and level of any presacral extension, intraspinal extension, which Aspang et al. Documented as an underappreciated finding requiring neurosurgical liaison and which changes the operative approach entirely. In addition to all of this, the presence of associated spinal dysraphism, such as a tetad cord, all of this can be seen on MRI. Echo is mandatory for large vascular tumors. High output cardiac failure may not be clinically apparent until the myocardium is already significantly compromised. So identifying it preoperatively allows for medical optimization before surgery. And then abdominal ultrasound remains highly useful for initial assessment of tumor composition and to detect hydronephrosis from ureteric compression, a finding that would mandate urological involvement preoperatively. CT angiography has an emerging role in planning vascular control for giant tumors. It provides a roadmap of the feeding vessels, their caliber, and their origin, enabling more precise preoperative embolization planning. On the question of biopsy, to be absolutely clear, routine preoperative biopsy of a resectable SCT in a neonate is contraindicated. In the hands of experienced teams, the combination of clinical examination, imaging, and tumor markers is sufficient for diagnosis. Complete resection with the coccyx provides both definitive treatment and pathological diagnosis in a single operation. Biopsy risks hemorrhage, capsular disruption with tumor spillage, and seeding of the biopsy tract, all of which worsen the patient's oncological status. The only legitimate indication for biopsy is in the atypical presentation of an older child where malignancy is strongly suspected and neoadjuvant chemotherapy is being considered to downstage a tumor that appears unresectable. So here we see an MRI of the abdomen and pelvis showing the teratomatous lesion in the pelvis and the sacral region. For the first one here shown is Altman type 3, and so that the tumor appears to be predominantly intrapelvic with abdominal extension. And here we have the type 2, where we have some external components, but with significant intrapelvic components. Here also is an MRI showing a mixed solid and cystic mass in the sacrococcygeal region extending into the pelvic cavity. So here we can see that it's displacing the rectum and even the uterus and the bladder anteriorly. So this is suggestive of Altman's type 2. Other things that we are seeing here, like the spine, appear to be within normal limits. Here is an intraspinal extension of a sacrococcygeal teratoma on MRI. So you can see the tumor here. And here we see the 3D reconstruction of the tumor. I'm showing its intraspinal extension. Just a rare occurrence. So, the staging system used for sacrococcygeal teratoma is a children's cancer study group and pediatric oncology group staging system for extragonadal germ cell tumors. This is a post-operative staging system based on the completeness of resection and the presence or absence of metastatic disease. So stage 1 denotes complete resection with negative margin. Stage 2 denotes microscopic residual disease. Stage 3 denotes gross residual or regional nodal disease. And stage 4 denotes distant metastasis. So this staging system directly informs the decision about adjuvant chemotherapy. Stage 1, patients do not require chemotherapy regardless of histology, whereas malignant SCTs at stage 2 to 4 would require chemotherapy. Now, informed consent for SCT resection must be comprehensive, honest, and documented in detail. The parents must understand hemorrhage is the most immediate life-threatening operative risk. The median sacral artery can be avulsed in seconds and blood loss can exceed the infant's total blood volume before it is controlled. This is not a theoretical risk. It is the leading cause of intraoperative mortality in sacrococcygeal teratoma surgery historically. Rectal and ureteral injury can occur, potentially requiring temporary colostomy. Sacral nerve roots injury can cause bladder and bowel dysfunction and lower limb weakness. Recurrence in 10 to 20%, even with complete coccygectomy, and this must be discussed, including the possibility of malignant recurrence. Wound complications vis-a-vis infection, dehiscence are extremely common due to the proximity of the wound to the anus. Some series reports dehiscence rates approaching 90% in the most technically challenging cases. And mortality, even with modern multidisciplinary care, remains a real risk for large vascular tumors. Parents must also understand that this is the beginning of a long surveillance journey, not a one-time event. So, for preoperative preparation, bowel preparation in units, particularly mechanical bowel preparation, is avoided because of the significant risk of fluid and electrolyte disturbance. Instead of preoperative rectal washout with warm saline on the operating table, um, instead a preoperative rectal washout with warm saline on the operating table effectively empties the rectum, reducing the risk of fecal contamination if a rectal injury occurs. In older children with large intrapelvic tumors, a 24 to 48 hour clear fluid diet with mild enemas may be appropriate. The Foley catheter serves two purposes. It decompresses the bladder, keeping it well out of the surgical field, and it provides continuous urine output monitoring, a sensitive real-time indicator of intraoperative fluid balance and perfusion. Ureteric stents, while not placed prophylactically, have a specific role in type 4 tumors, where the ureters may be incorporated into or displaced by the tumor mass. A urologist performing intraoperative cystoscopy to place lighted stents can significantly facilitate the identification of ureters and prevent inadvertent injury. Prophylactic antibiotics. Um, a single dose of a broad spectrum antibiotics like cefoxitin or ampicillin gentamicin administered within 60 minutes of skin incision is standard. The spectrum must cover both skin flora and enteric organisms given the rectal proximity of the dissection. The pain management. The traditional caudal epidural block is not possible with a sacrococcygeal mass obstructing the caudal space. Instead, um, intravenous paracetamol, opioids titrated carefully, and local infiltration of the wound edges with bupivacaine as closure are the mainstays. Regional techniques such as lumbar epidural, if placed before positioning, may be considered in selected cases after tumor removal. The emerging role of laparoscopy in SCT resection deserves specific mention. For Altman type 3 and 4 tumors, where the primary challenge is the large intrapelvic component and the inaccessible vascular pedicle, laparoscopy allows early identification and clip ligation of the median sacral artery from above before embarking on the posterior sacral dissection. This single maneuver can dramatically reduce the risk of catastrophic hemorrhage during the perineal phase. So, Al-Yusuf, Kedre, and Yamoto et al. Have all reported this approach with favorable outcomes. Endoscopy, particularly endoscopic tattooing of the plane between the tumor and the rectum, can also facilitate safe dissection. So we want to, of course, ensure we follow these WHO surgical safety checklists. The table here is important for practice because high-risk tumors are not rare in our setting. We frequently encounter giant tumors that would be considered operative emergencies. Giant cystic sacrococcygeal teratomas causing respiratory compromise can undergo stage cyst decompression. So we have needle aspiration of the dominant cystic components under ultrasound guidance to improve ventilation and hemodynamics before definitive resection. This is not curative, but it creates a safer operative window. Giant solid or mixed vascular tumors may benefit from preoperative endovascular embolization of feeding vessels. Where interventional radiology capability exists, selective embolization of the median sacral artery and the major internal iliac branches can reduce intraoperative blood loss substantially. Where endovascular capability is not available, planned operative devascularization early in the abdominal phase before the perineal dissection begins achieves the same goal. High hypocardiac failure must be medically stabilized before surgery. This may require diuretics and in severe cases, inotropic supports. Operating on a neonate with a dilated, poorly contracting ventricle is a catastrophic combination with expected intraoperative hemorrhage. 2 points deserve emphasis here. First is Currarino triad, which is the association of presacral mass, which can be an SCT, sacral agenesis or hemisacrum, and inerectal malformation. This must be specifically looked for in every type 4 and 3 case. Missing a sacral defect or an inerectal anomaly on preoperative imaging changes the operative strategy entirely and affects long-term functional prognosis. Second, NICU bed reservation is not administrative formality. These babies require intensive post-operative monitoring, and having a confirmed NICU bed before you incise is an absolute necessity. Anesthetic management of SCT resection is one of the most challenging in all of pediatric anesthesia. Allow me to go through this systematically because as surgeons we must understand why our anesthesiology colleagues are dealing we must understand what they are dealing with so that we can communicate effectively with them throughout the case. The pathophysiological basis of the anesthetic challenge is a tumor behavior as a large arteriovenous shunt. Blood is perpetually being diverted from the systemic circulation into the low resistance vascular bed of the tumor, creating a chronically elevated cardiac output state. The myocardium compensates through eccentric hypertrophy and volume overload. When we then expose the infants to the hemodynamic stresses of positioning, blood loss, fluid shifts, the margin of safety is narrow. For induction, ketamine is the agent of choice. Its sympathomimetic properties maintain heart rates and blood pressure in a preload dependent unit. Volatile agents can cause myocardial depression and systemic vasodilation, which is particularly dangerous in a patient who is already in a compensated high output state. The triad of deaths, acidosis, hypothermia, coagulopathy must be actively prevented. And these three elements are mutually reinforcing. The operating room temperature should be at least 26 degrees Celsius, all fluids warmed, first ear warming blankets applied, and the baby on a warming mattress. These are not optional environmental comforts, they are components of the resuscitation strategy. Vascular access, at least 2 large bore peripheral IVs in the upper extremity, not lower limbs, which may be in a compressed or elevated operative field. A central venous catheter for pressure monitoring and rapid volume administration, and an arterial line for beat-to-beat blood pressure monitoring and frequent arterial blood gas sampling. Massive transfusion protocol should be pre-activated for any large solid tumor. The target transfusion ratio is 1 to 1 to 1, which is packed red cell to fresh serum plasma and platelets. Ionized calcium must be monitored and replaced frequently because the citrate in stored blood products chelates calcium and causes myocardial depression during rapid transfusion. Potassium must be monitored for hyperkalemia. Glucose monitoring is essential in units who have minimal glycogen stores. And then there are some phase-specific anesthetic challenges that one must pay attention to. During positioning, particularly the flip from supine to prone in combined abdominosacral cases, all lines, the endotracheal tube, the monitoring leads must be secured before the patient is moved. During dissection and devascularization, sudden drops in end-tidal CO2 signal decreased cardiac output or pulmonary embolism. The anesthetist must be ahead of events, not reacting to them. After tumor removal, the elimination of the vascular steal causes an acute increase in systemic vascular resistance and afterload. Hypertension and cardiac strain are expected, and the vasodilators may be required transiently. Post-operatively, these patients are not extubated in the operating room. They go intubated to the NICU or PICU and remain ventilated until they are hemodynamically stable, normothermic, and no longer coagulopathic. Positioning is determined primarily by the Altman type and the planned approach. For type 1 and 2 tumors and selected type 3 tumors with limited pelvic extension, the prone jackknife skydiver position, alright, provides optimal exposure of the sacrococcygeal region. The table is flexed, the buttocks are at the highest point, and critically, the buttocks are taped, right? Buttocks are taped apart to open the natal cleft and improve midline access. The chest and pelvis are padded with rolls, right, to allow the abdomen to hang free, preventing abdominal compression that would impair diaphragmatic excursion and increase intraoperative airway pressure. All pressure points are padded. The eyes, the breasts in female infants, the genitalia in male infants, and all bony prominences. For type 3 and 4 tumors, requiring a combined abdominosacral approach, stage positioning is necessary. So the patient is first positioned supine or in lithotomy for the abdominal phase, then repositioned prone for the perineal or sacral phase. This repositioning must be carefully coordinated between the surgical and anesthetic team, securing all lines, the ET tube, the monitoring leads before the flip, and reconfirming all connections afterward. For laparoscopic assisted approaches, the supine or lithotomy position is maintained for laparoscopic mobilization and vascular control. Then the patient is repositioned prone for the sacral excision. In selected cases, the entire procedure may be completed without repositioning by using a combined prone and lithotomy setup. The approach decision is one of the most important judgments you will make in SCT management. It must be made preoperatively in the clinic in front of the MRI, not in the operating room. So type 1 and most type 2 tumors, a pure perineal or sacral approach provides adequate exposure with low morbidity. The external mass is the dominant component and the presacral extension is limited enough to be mobilized and delivered through the perineal incision. Type 2 and 3 tumors with large intrapelvic components, a combined abdominosacral approach, increasingly laparoscopically assisted, is a safe strategy. The intrapelvic components cannot be safely delivered through a perineal approach without risking injury to the pelvic viscera. And the cranial dissection from above allows precise control of the median sacral artery and safe mobilization of the pelvic structures before turning the patient for the perineal phase. Type 4 and predominantly presacral tumors, the abdominal approach, open laparotomy or laparoscopy assisted with sacral completion is the standard. The entire tumor must be mobilized from the pelvic organs before the coccygectomy can be performed safely. For giant or highly vascular tumors, regardless of type, they require an initial devascularization step, which can be endovascular or open, before definitive resection to prevent catastrophic hemorrhage. Now, to the procedure itself. The patient is prone, prepped, and draped. A Higgins dilator or a rectal probe has been placed in the rectum and secured with a suture or a gloved hand. The Foley's catheter is draining and the team is briefed. Blood products are in the room. So now to the incision. The incision selection is the first operative decision. Options include a vertical elliptical incision, which is used for small or moderate type 1 tumors with intact skin. It provides a relatively concealed scar that lies within the natal clefts. It is ideal for lesions with mild skin redundancy. Then there's a posterior sagittal incision used for small or intrapelvic components like type 4 with no external mass. It follows the midline posterior sagittal plane and provides excellent access to the presacral space without significant skin excision. Then there's the modified chevron, also known as the inverted V incision, which is the workhorse for large tumors requiring wide exposure. So the traditional classic chevron has largely been abandoned because it produces protuberant dog ears and extends below the infragluteal crease onto the posterior thighs, causing distressing buttock deformity. The modified chevron addresses this by redirecting the limb of the V to stay within the gluteal region. And then there's the circumferential incision, which is considered the gold standard for giant pedunculated tumors, where the base of the tumor is narrow. The incision encircles the tumor base circumferentially, allowing complete excision of all involved skin. This inevitably creates a significant skin defect requiring formal reconstruction with flaps. The table on this slide um, is a practical um, decision guide. So you can study it because choosing the wrong decision commits you to a suboptimal closure, and no amount of technical ingenuity at the end of the case can fully compensate for an incision that was not designed for the defects you have created. So move on to dissection and exposure. Once a skin incision is made, you raise skin flaps exposing the stretched gluteal muscles. These muscles have been displaced laterally by the growing tumor. The key principle now is your dissection plane is directly on the tumor capsule, not through it. So circumferential dissection proceeds in the avascular areolar space around the tumor capsule. Use sharp mesenbum scissors for fine dissection and electrocautery for deeper tissue. Skin hooks and Lagenbach retractors can help elevate the flaps, and then peanut swabs and blunt digital dissection can be used to separate the planes. The rectum must be protected at every moment. Your Higgins dilator is your guide. Periodically rest your non-cutting hand against the dilator through the rectal wall to confirm your plane. If you feel the dilator, you are on the posterior rectal wall and you need to move posteriorly onto the tumor capsule. Sometimes it is easier to identify the sacrum and coccyx early in the dissection. So before completing the circumferential dissection, in other cases, the circumferential dissection is completed first and the coccyx is addressed last. The approach depends on tumor size basically, the vascularity, and the ease of identifying anatomical landmarks. Either way, the coccyx is transected at the sacrococcygeal joints using cautery or a cold knife, taking it en bloc with the specimen. The gluteal muscles are gently reflected off the tumor capsule, and as you dissect superiorly towards the pelvis, the presacral space opens. Here you are entering the territory of the median sacral vessel, the presacral venous plexus, and the tumor's cranial attachments. So meticulous hemostasis at every step, because a clear field allows precise dissection, and imprecise dissection in a bloody field is how the rectum gets injured. Now to the vascular control. This is the moment of maximum danger in every SCT resection. So early identification and control of the median circulatory is mandatory. This vessel lies in the midline on the anterior surface of the sacrum. In a pure posterior sacral approach, it is encountered as you dissect the tumor's superior pole away from the sacrum. You will identify it running in the midline, so you can suture, ligate, or clip it, and do not rely on cautery alone for a vessel of any significant size. The lateral sacral arteries and branches of the internal iliac arteries feeding the tumor from the sides must also be systematically identified and controlled as the lateral dissection proceeds. So you use bipolar diatomy for the smaller vessels and absorbable suture, either 2 or 3 ovicral, or silk ties for larger ones. Modern vascular sealing devices like ligature and seal can facilitate simultaneous cut and seal dissection and are particularly useful in the confined presacral space. Maintain constant communication with your anesthesiologist. If you are about to open a major vessel, warn them. I'm about to divide the median sacral artery. Be ready. So a prepared anesthesiologist who has blood products running can compensate for blood loss that would be catastrophic to an unprepared team. The principle of local devascularization before tumor delivery is the cornerstone of hemorrhage prevention in SCT surgery, as this has been demonstrated by Elgendi, Slipov, Perederi, and Kamata et al. Now the coccygectomy. This is the single most important step of the entire operation. I will say it again, the coccyx must come out en bloc with the tumor, in every case without exception. The biological rationale, as established by Gross and Clatworthy in 1951 and validated by every subsequent series, is that the totipotent cells giving rise to SCT are concentrated in the coccyx. Leaving even a fragment of coccygeal tissue provides a nidus for regrowth, and the data are unambiguous. With complete coccygectomy, recurrence rate is less than 10%. Without complete coccygectomy, recurrence rate is higher than 37%. This is not a marginal difference. Alright? It is nearly a fourfold increase in recurrence for a technical omission that takes less than 5 minutes to perform correctly. So use a periosteal elevator, either the Freya or Cobbs, to strip the soft tissue from the coccyx. The coccygeal joint is identified, usually at the junction of S5 and the first coccygeal segment, and disarticulated with cautery or a knife. Rongers or bone nibblers can be used if the joint is calcified. Cautery controls the bleeding as the bone edges. Rescola et al. In their review of critical elements of pediatric SCT surgery list coccygectomy as a non-negotiable technical priority above all others. Fee and Elgendi et al. Are consistent. When teaching residents, says they mentioned that they tell them that they may encounter every complication manageable. Rectal injury can be repaired, bleeding can be controlled, but if you leave the coccyx behind, you have put a time bomb in the patient, and the malignant recurrence that follows may not be salvageable. So here is a picture that shows an attempt at removing the coccyx. Here it's been done using the size 15 blade, and here also we are seeing the block removal of the tumor together with the coccyx, and of course after making sure I've secured vascular control vis-a-vis the median sacral vessels has been either ligated or clipped using observable or unobservable sutures. And then move on to tumor delivery. So when the coccyx is transected, the lateral dissection completes and the vascular pedicle controlled, the tumor is now attached only at its presacral component. So gentle sustained traction on the specimen combined with careful sharp dissection under direct vision will deliver the tumor. We want to avoid capsular rupture at all costs. Tumor spillage is associated with higher local recurrence rates and, in malignant cases, potential peritoneal dissemination. So if the tumor is cystic or at risk of rupture due to size or fragility, controlled aspiration of the cyst contents before attempting delivery may be necessary, but in most cases the intact capsule is the goal. Use a finger in the rectum during this final delivery phase. It confirms, as you can see here, finger in the rectum, and this confirms that the rectal wall is clear of the dissection. As Shinoi et al. And multiple operative series describe, feeling the tumor separate from the erectile complex under direct tactile control is the safest way to ensure sphincter preservation. So here we see the exposed rectum and then separation of the tumor from the rectal wall, and here we can see a completion of the ventral dissection of the tumor. And then the next thing is reconstruction, which is not an afterthought. It is the third critical act of the operation, following oncological resection and hemostasis. The quality of reconstruction determines long-term functional outcomes and patient's quality of life. So pelvic floor reconstruction involves the levator ani muscles which were divided or displaced by the tumor, and this must be reapproximated in the midline behind the rectum, starting from the most inferior point and progressing superiorly. This restores the anatomical support of the pelvic floor and positions the erectile complex in its proper relationship to the pelvic cavity. Failure to reconstruct the pelvic floor leaves the erectile complex prolapsing into the dead space and dramatically increases the risk of long-term fecal incontinence. The anus will then assume a near normal configuration, offering the best possibility of good fecal continence. So after pelvic floor reconstruction, an approximation of the muscles, we can place a suction drain, usually Jackson Pratt or Redivac drain, in the perirectal space, brought out through a separate stab incision. This prevents the accumulation of blood and seroma in the dead space, which is a significant source of wound infection and dehiscence. And then gluteal reconstruction can proceed, and this approach depends on the defects. All right. So for moderate defects after moderate sized tumors, simple sagittal flap advancement with midline closure is adequate. For large defects, a V-shaped closure or an inverted Y closure accommodates the skin redundancy. The classic chevron incision creates dog ears that extends below the infragluteal crease, producing an unacceptable buttock deformity. So the modified chevron or inverted Y closure addresses this. And then for giant tumors, after circumferential excision of the tumor and surrounding skin, a formal flap reconstruction using bilateral gluteal rotation flaps may be required. The rotated Mersey's closure distributes the tension of closure across multiple planes. The ideal final appearance, right, as illustrated in some series, resembles the Greek letter pi. So we have a symmetric, aesthetically acceptable um, um, result with scars contained within the gluteal region and a preserved midline cleft. So scars extending below the infragluteal crease onto the posterior thigh are a cosmetic failure and should be avoided by careful incision planning from the outset. Some papers have been published by Abu Zaid Abdelhamid, where he talked about vertical wound closure following SCT excision as an approachable aesthetic solution. And so we can see some cases, series that he had presented. Here we see a 9-month-old girl presenting with sacrococcygeal teratoma, Altman type 2. And here we see the MRI that shows the deep cystic component of the tumor. Okay, here's a solid component. So here we see the marking of the skin incision, which is a vertical elliptical marking with the patient in the prone position. And here, after we completed our dissection, so we have a vertical midline wound closure. So, and here we see the good aesthetic outcome at 3 weeks post-op follow-up. Here is also another patient after sacrococcygeal teratoma resection. So the pelvic floor muscles are represented in the midline before the rectum. And here we see a 3-day-old boy presenting with a large protruding sacrococcygeal teratoma. Here we see the patient in a prone position with the site of incision also marked on the skin to remove the involved unhealthy skin with the mass. Here we see the modified vertical skin closure, which is the inverted Y I talked about, to accommodate for skin redundancy at the lower end of the wound. Remember, we talked about the for large defects, a V-shaped closure or an inverted Y closure accommodates the skin redundancy. Okay, and here we see the skin wound 3 weeks after. All right, and then our picture here shows the beautiful aesthetic outcome um, of vertical wound closure after sacrococcygeal teratoma excision in 5 different cases. So here you'll see the beautiful cosmetic outcome in all of these cases. Here's a 9-day-old boy presenting with a large protruding sacrococcygeal teratoma. Okay, we have the patient here in the supine position demonstrating displacement of the anus. So um, you see the anus here displaced, and the patient is then placed in the prone position as operation. You can note the marking, the vertical elliptical marking on the skin for the site of the coccyx here, and also the incision. So the tumor bed is excised, tumor bed is displayed after excision of the tumor, and then we see satisfactory cosmetic outcome after 2 years. So the same story is seen in multiple other cases. Here we see a 5-year-old girl presenting with a large irregular protruding sacrococcygeal teratoma. And so same here, as you can see, we have the modified inverted Y skin closure to accommodate for skin redundancy at the lower end of the tumor. And so here we see the cosmetic outcome at 6 months and at 2.5 years. So Abu Zaid had shown that a vertical rather than transverse wound closure gives a better cosmetic outcome, and it is both feasible and advantageous in terms of cosmetic outcome, provides a well-hidden scar in the natal cleft, and preserves normal contouring of the buttocks. And so we have other pictures that demonstrates this. And then moving on to the abdominal and laparoscopic components. Um, when the abdominal phase is required for type 3 tumors with large intrapelvic components and all type 4 tumors, it is performed before the sacral phase. So we have the open abdominal approach where a phalansteal, a lower midline or a transverse lower abdominal incision provides access to the presacral space from above, and the peritoneum is entered, the small bowel retracted, and the presacral dissection performed under direct vision. The ureters are identified and protected, the aorta and iliac vessels are visualized, the median circulatory is ligated at its origin, and then the intrapelvic component of the tumor is mobilized from the rectum, the bladder, and the pelvic side walls. And once fully mobilized, the abdominal wall is closed and the patient is turned prone for the sacral phase. So you have the incision here, and here we have attempt at vascular control by ligation of the median sacral artery. So here we have the classic chevron is a modified chevron incision being made here, and here we see the posterior sacral approach being demonstrated for one that has not much of a sacral component, and here through the abdominal approach we then see the mass protruding just between the um, just in the close vicinity to the sigmoid rectum and urinary bladder. And here, this is how the mass has been excised, and we now turn posteriorly. We can see the sacrum, the coccyx, and then we can see the intrapelvic parts has been has been pulled out, as well as the extrapelvic parts of the tumor. So here we have a type 3 tumor basically. We have the abdominal parts in this first diagram, and then we have the mass being pulled out of the posterior sacral incision. You can also visualize the urinary bladder and the sigmoid in that case. Now for laparoscopic assisted approach. This is increasingly the preferred technique at high volume centers. Ports are placed at the umbilicus, all right, with the camera port, and then laterally, which are the instruments ports. The laparoscope provides excellent magnification of pelvic anatomy. So early clipping of the median sacral artery under direct laparoscopic vision before any perineal dissection is the key advantage of this approach. Al Yusuf et al., Kedri et al., Yamamoto et al. Have all reported this technique with less blood loss and faster recovery than the open approach. Laparoscopy does require surgeon proficiency in pelvic laparoscopy in small patients, and the learning curve is real. So after the abdominal mobilization, open laparoscopy, the specimen is delivered and blocked through the perineal incision. Resection margins are confirmed visually, and then the specimen is sent for full pathologic analysis, including all margins. So here we see a laparoscopic view that shows the mass. So coccygeal mass is saying just big long arrow pushing the rectum. You can see here, and anteriorly to the right side. You can see the uterus just close to the center of the mass. And here we see the mass being delineated with dissection, progressive dissection of the peri-mass structures. So we have the colon here, up here, which has been retracted to the anterior abdominal wall for proper delineation of the retrorectal space. And here we see intraoperative laparoscopic view again with the tumor which is being dissected free of surrounding structures. Now, for the giant hypervascular tumor, one of the most dangerous operative scenarios in pediatric surgery, several special considerations apply. So, preoperative endovascular embolization of feeding vessels, where available, can reduce intraoperative blood loss by 50% or more, and this should be performed 24 to 48 hours before the planned resection. Intraoperative devascularization before definitive tumor resection, as mentioned, to be achieved through the abdominal or laparoscopic approach, and is the minimum standard where endovascular capability is not available. A staged approach, which is essentially initial devascularization procedure followed by delayed resection 5 to 7 days later, once the tumor vascularity has involuted, may be appropriate for the most extreme cases, particularly in premature or hemodynamically unstable neonates. And then cell salvage should be available in the operating room through their use, though their use, requires judgment in malignant cases. Autologous blood salvage risks reinfusing malignant cells and is generally contraindicated. So one should be careful with cell salvage in this kind of patients. And then there's a post-operative care, which is the immediate post-operative management, which is as important as the operation itself. As already discussed, all neonates who have undergone major SCT resection go directly to the NICU or the PICU intubated and remain ventilated until they are hemodynamically stable, pneumothermic, and no longer coagulopathic. So the wound care is a major challenge,